Let's learn about carbapenems and beta-lactam inhibitor combinations. Is the first in class of novel beta-lactam inhibitors. Avibactam is a novel first in class non-beta-lactam inhibitor from a new chemical class diazepam cyclooctane. The older beta-lactam inhibitors, all structurally related beta-lactams, cause acylation and subsequent irreversible inactivation of the beta-lactams. That is suicidal inhibition. Avibactam differs from these agents in three aspects. It does not have a beta-lactam skeleton. Instead, it is a DAPCO, so low propensity for hydrolysis. It has an extended spectrum of beta-lactam inhibition, and mechanism of inhibition is reversible. From the chart, the activities of avibactam and other beta-lactam inhibitors. But clavulanic acid is active against TAME and SHV. It has no activity against CTX, MC, KPC, OXA, IMP. While tazobactam has nearly the same reactions. While avibactam is active against TAME, CTX, MC, KPC, OXA. However, it doesn't have activity against IMP and BI. But vaborbactam has activity against all except OXA and IMP. While relebactam similarly, it has activity against all except OXA and IMP. Broader spectrum of beta-lactam inhibition. Avibactam potency is 10 to more than 100 times to that currently available therapeutic inhibitors. As you can see from these comparisons. If you see, avibactam doesn't have a classical beta-lactam ring and it is resistant to the hydrolysis. They are all inhibitors of serine beta-lactamases. Actions of avibactam, vaborbactam, relebactam. If we compare, clavulanic acid is active against all. Doesn't have activity against CTX, MC, KPC, and OXA, IMP, while it is active only against TAME. Tazobactam is active against TAME and no activity against MC, KPC, OXA, IMP. But avibactam is active against TAME, CTX, MC, KPC, OXA. However, it doesn't have an activity against IMP. That's the active comparison of the activities of avibactam, vaborbactam, relebactam. You can refer to the details in the article from Wong, published in the Drugs 2017 publication. Ceftazidime has an extended spectrum of cephalosporin with activity against Enterobacter and Pseudomonas aeruginosa. It binds to the penicillin binding proteins leading to bacterial cell lysis. While avibactam is a novel non-beta-lactam inhibitor with a unique mode of action. It has a high affinity for class A, C, and some class D beta-lactamases, including ESBLs, KPC, and MC. The spectrum of activity of ceftazidime avibactam includes complicated urinary tract infections active against gram-negative organisms like E. coli, Klebsiella, Proteus, Pseudomonas, Enterobacter. And it is also active against complicated intra-abdominal infections caused by gram-negative organisms such as Citrobacter, Enterobacter, E. coli, Klebsiella, and Pseudomonas. It is also active against hospital-acquired pneumonia, including ventilator acid pneumonia caused by gram-negative organisms like Klebsiella, Proteus, Pseudomonas, Serratia. It is also active against non-susceptible bacteria, including Staph aureus, medicine-resistant as well as medicine-susceptible anaerobes, Enterococcus, Tenitrobomus, and Acinetobacter. In vitro combination studies with ceftazidime avibactam and metronidazole, tobramycin, levofloxacin, vancomycin, linezolid, cholecystine indicated that neither synergy nor antagonism have been demonstrated. This you can refer to the article on intra-abdominal infections to understand about the dosage frequency, infusion time, and duration of treatment. The ceftazidime avibactam pharmacokinetic properties include protein binding of ceftazidime 15%, while avibactam is 8%. Similarly, we can get to the details about distribution, elimination, and type of pharmacokinetics in regards to this dose linearity and acclimation and lung penetration from the article Joseph et al. Published in Pharmacotherapy 2015 year. In safety, most common iodine reactions in more than 5% of patients were Coombs direct test positive and nausea and diarrhea. Succinate difficile acetate diarrhea have been reported from mild to life-threatening. It is contracted in patients with hypersensitivity and it has been eliminated by the kidneys, hence those should be reduced according to the degree of renal impairment. It has also been reported with neurological sequelae. The effectiveness of ceftazidime avibactam as salvage therapy for treatment of infection due to OXA-48 carbapenems producing Enterobacter. Salvage therapy for most intra-abdominal infections, bacteremia, and carbapenems producing Enterobacter for OXA-48 producing Enterobacter. About 57 patients with carbapenems producing enterovaccine treated with ceftriaxone avibactam for between April 2016 to December 2017 that met of the following criteria: that poor clinical course, contraindicated to unacceptable risk of toxicity associated with the use of appropriate antibiotic options, and toxicity of previous antibiotic treatment. And source and severity of the infections is per the slide. It is adapted from the source A8 Antimicrobial Chemotherapy Journal up to year 2018. Of the ISRS were as follows: certified ivermectin has 100% sensitivity as compared to colicin 75%, imipenem 3%, and imipenem MSC less than 8 was about 47%. So the outcomes were the clinical and microbiology cure was achieved in 77% and 65% of the patient respectively. Microbiology failure was observed in 10% of cases. 2% developed acute kidney injury, but there were no discontinuation related to ceftriaxone ivermectin treatment. Case caused mortality rate at 14 and 13 days were 14 and 22% respectively. The only factor related to 14-day mortality was an increment CP score more than 7. So the results of monotherapy versus combination therapy outcomes, the clinical cure was significant as well as the microbiological cure. Infection with a median time of 41 days from the end of treatment. This patient had initially treated with for a median of 13 days. All still in isolated recurrence confirmed to be OXA48 producers with no increase in ceftriaxone ivermectin compared to the original isolates. This patient was treated with ceftriaxone ivermectin monotherapy, and all but one patient was clinically and microbiologically cured. Conclusions were ceftriaxone ivermectin shows promising results ever in monotherapy for the treatment of patients with severe infection due to OXA48 producing enteropathy and limited therapeutic options. The emergence of resistance to ceftriaxone ivermectin was not observed. What are the clinical characteristics and prognosis of infection caused by OXA48 carbapenems producing enteropathy? The study was carried out between OXA-CPE and OXA48 like infection who had received 72 hours of treatment with ceftriaxone ivermectin. An analysis of 24 episodes of infection was done. Higher colonization was about 20. The results were as follows as per the slide. It is you can refer to the details from the International Journal of Antimicrobial Agents 2018 publication. Epsilon pneumonia was present in nearly 96% of the episode and equal in 4% of the episode, and the sensitivity of ceftriaxone ivermectin was 100% as compared to 4% of ceftazidime alone, and amikacin was 79%. So ceftriaxone ivermectin fared well as compared to other antibiotics. All the isolates were susceptible to ceftriaxone ivermectin with MSC less than 1 milligram per liter. Clinical cure was achieved in 62% of the episode. There were no differences in the clinical cure between episode with ceftriaxone ivermectin was used at the initial treatment. 16% of the patients experienced treatment adverse event during treatment with ceftriaxone ivermectin like diarrhea or progressive thrombocytopenia, cortisone and others. And 90-day mortality rate was about 8%, 20% respectively. No difference in 90-day mortality was observed between episodes with monotherapy and combination therapy. Infection-related mortality at 30-90 days was 8%, 12% respectively. The conclusion were that despite a small sample size, the study showed that ceftriaxone ivermectin is an effective drug for the treatment of infection due to OXA48 carbapenems producing enteropathy. The results show better safety profile than expected of the current based available therapy. Ceftriaxone ivermectin may be an alternative that is as effective and far less toxic than the best options currently available. You can refer to the article A focus on extended spectrum beta-lactam producing enteropathy, carbapenems, enteropathy, and pseudomonas anism with difficult to treat resistance from the IDSA publication. Recommendations are that the prefer an antidote treatment recommendation in this guidance assume that causative organisms has been identified and in vitro activity of antibiotics has been demonstrated. Empirical therapy recommendations are not provided. The recommendation on duration of therapy are not mentioned. CRD clinical isolate is carbapenems producing, and if it is, the specific carbapenems produced is important in guiding the treatment decisions. Knowledge of whether the CRD is carbapenems producing is instrumental in guiding the treatment decisions. If, for example, the source of infection in the pyelonephritis, the preferred treatment is ceftriaxone ivermectin with alternate treatment as once daily aminoglycosides. It was observed that the recommended antibiotic treatment options for carbapenem enterobacterial, assuming in vitro susceptibility agents, are as follows. The infection outside of the urinary tract resistant to ertapenem, meropenem, were treated by ceftriaxone ivermectin, meropenem, vaborbactam, imipenem, serostim, teladoc.